My name is Gordon Fung. I am a clinical professor of medicine at the University of California in San Francisco, California, USA. And I was invited to give a presentation today on a case presentation of orthostatic hypotension with recent advances. And I presented a case of a 78-year-old man who had recurrent syncope in situations where he was driving and came to a stop and then was pulled over by the CHP because he was found slumped over on his driving steering wheel. The second case was the second situation was when he woke up in the morning, was getting ready, and his wife heard him collapse in the bathroom, and so found him as he had injured himself. Both times he had gone to the emergency department and had a thorough evaluation, and nothing was found except for an echocardiogram that demonstrated a mildly dilated aortic root. By history, he had a history of hypertension, which was well treated on a long-acting calcium channel blocker and did fairly well, but continued to have these episodes. So when I saw him, we completed the workup and started to modify some of his medications, and he did well initially, but continued to have episodes. And so ultimately we found that the only way we were able to control this was to completely eliminate all of his blood pressure medications as a cause for his orthostatic hypotension. And so how I found out that he had actually had a tilt table test, which is one of the recommended tests for this evaluation, was that he mentioned then that one of his evaluations, he did this, and he said he was never going to do it again because he had such a dramatic response and he almost felt like he died. But he was just reported to have loss of consciousness that spontaneously reversed when he was put back in the supine position. So the workup actually includes a complete history and physical plus a tilt table test. And the tilt table test is actually designed so that we can measure the autonomic response to positions without the use of extra musculature. And so there are classic responses, one that reveals the classic neurocardiogenic syncope, which is the classic vasovagal syncope. The second one is a dysautonomic type of response where the blood pressure will drop, but the heart rate remains relatively the same. And now a newly identified condition called POTS, or postural tachycardia syndrome, where the heart rate rises with the change in position, and many times it rises greater than 30 beats per minute, which is the key to finding or looking out for that. Currently, there's no specific management for that, but patients can continue to have recurrent syncope, so we do try other things. Now, from mechanisms, there have not been a whole lot of different etiologies found for this particular condition, but looking at the disease itself, we found that there are several subclasses of syndromes associated with. So the chronic orthostatic hypotension with autonomic dysfunction is seen where the autonomic dysfunction can occur in patients with Parkinson's, some patients with the classically described Shy-Drager syndrome, now known as multiple system atrophy, and finally with diabetes, amyloid, things like that. The chronic orthostatic hypotension is seen in actually up to 60% of patients in the hospital and has been associated with increased morbidity and mortality in the hospital, as well as a predictor of future atrial fibrillation. It's also been seen in one of the other syndromes that is being seen in the elderly population called postprandial hypotension, and this is seen in about 45–50% of patients in nursing homes that have been looked at in other studies. And finally, the POTS syndrome is a new one. Finally, in terms of management, the usual treatments that we have started with has always been education and conservative measures like advising patients to move their arms and legs to increase their venous return prior to getting up more slowly, as well as eating smaller meals, eating them more frequently. And the one thing that is definitely important to remember is to eliminate all the potential challenges or stimulants like medications. Tranquilizers was a big one found to be commonly used in the elderly population. Antihypertensives, as in my patient, we had to eliminate all of them. And other agents like diuretics that can lower blood volume. But the new treatment that has come to market this year, recently approved by the FDA in the United States, is droxidopa, which is a prodrug that actually is converted to norepinephrine and actually allows for increased norepinephrine levels in the blood so that it can eliminate the drop in blood pressure when one stands up and presents with recurrent syncope. So the official definition of orthostatic hypotension is after standing for 2 to 5 minutes, a drop in blood pressure of greater than 20 millimeters of mercury in the systolic, 10 millimeters in diastolic with symptoms.